You can do the whole thing.
No, I'll let you start it. I'm not going crazy here.
All right, here we go in 3, 2, 1. What's up, y'all? Welcome to the Sports Medicine Broadcast. We are back at the Sports Medicine Update 2017. I'm thankful for Bob Marley and the team here that puts this on. It's a great educational experience, and we have Dr. Michael Greaser talking about foot, ankle anatomy. He's kind of a specialist there. I know he talked last year on the podcast about foot and ankle, and Sean's got a bunch of questions from the presentation, and so Sean Reedy, welcome again to the podcast. Thanks for helping me out. So go ahead.
All right, Doctor. The first thing that stood out to me was the Lisfranc stuff,
Right.
And especially since one of the things that you did or you said was something I see misdiagnosed a lot. So how is one way? I know you obviously talked about your diagnosis there in clinic. How's one way that us as athletic trainers can assist that and can catch up on that? Coming from the collegiate setting, it was something that we see a lot of, and
right.
the Lisfranc to me was one of the, it's terrible injury.
Yeah.
And you even in your type 1 or first grade 1 sprain or injury, you're dealing with potentially season ending because of how long it can take to heal. So can you kind of guide us on that? I guess those are several questions encompassed to one.
Yeah. So I think they can be sort of elusive is what I tell you. And I think that, the first thing is you have to have a high index of suspicion. So any player who, describes an injury where someone fell on their foot or they landed on their foot and twisted it awkwardly, I think you have to at least examine the midfoot. And, palpation is key, right? I mean, I think if you put a thumb in between that first and second metatarsal base and it produces pain, and then you grab their foot and shuck that second and the first metatarsal down near the toes and it produces pain at the midfoot, that's a pretty good indication that there is, at the very least, a stretch injury to those joints. And sure, those tests can indicate other things. I mean, we see pain with metatarsal stress fractures associated with those tests, but I think that sort of keys you into, this player is having a hard time weight bearing. They are localizing pain to the midfoot. They describe an injury that could result in a midfoot sprain or Lisfranc sprain, and if that's the case, then I think those patients require evaluation with X-rays at the very least, and should be sent on to the orthopedic or sports medicine doc. So
I think your biggest thing, or what you biggest said there, was that mechanism of injury. So watching that patient, how he comes down, kind of explain that, because I know every time that I would be watching the game, rugby, football, anything, see somebody in soccer kind of come down that body, or especially in the football setting where they kind of wrap up from behind, come down, you've got that foot from behind them. My thought always goes to the foot and the Lisfranc. So kind of explain that if you could.
So usually, we see a lot of these in linemen, just due to the fact that they're in the scrum almost, and they're up on their toes, and then they all weigh 300 plus pounds, and someone basically falls directly on their plantar flex foot and has a rotational mechanism in addition to that, and then that is your mechanism, right? So your foot's plantar flex, you're pushing off the guy in front of you, and then your buddy falls down on the back of your foot, and you twist at the same time, and all of a sudden you've disrupted your midfoot ligament. So I think you have to be aware of how these things happen, and most of these people can't weight bear. They're limping pretty bad, and most of these injuries are significant enough to where they don't want to put weight on their foot. So I think you just have to be suspicious of that sort of injury and send them on for evaluation. I mean, these are things you don't want to miss for sure.
Mm-hmm. Well, I know you talked about the 3 different levels or 3 different stages of the injury, and 2 of which being operative and 1 of which non-operative. What's the prevalence in both that you see? I mean, obviously, potentially more are going to come to you that are operatively, just because the athletic trainer is going to catch it, or the person is going to catch it, whomever, and or they're continuing to have pain with it. But kind of how prevalent is?
I'd say I suspect that it's about 50-50. I see more, I'd say even in my practice, I see about 50% that are stable and we treat them non-operatively in a boot, and the other 50% require surgery. Now, there are probably more non-operative sprains out there that just never make it to my office, and whether it's a misdiagnosis or they sort of just walk it off and they get better because it's a stable injury. I think there's probably more non-operative sprains out there that I just don't see. In my practice, it's approximately 50%, I would say, that end up needing surgery, and 50% don't.
Now, what would you, I know we kind of went all over diagnosis already, but what would be one thing that you would say for those athletic trainers for that, differential of just a regular midfoot in comparison to a true Lisfranc?
So it's hard. Some of these patients will have gross instability. So, if they have a bad Lisfranc injury, that they have disruption in that first tarsometatarsal joint ligaments, as well as your traditional Lisfranc ligaments that hold the medial cuneiform and the second metatarsal base. A lot of those patients, you'll be able to sort of, if you compare one side to the other, their foot will feel unstable. You'll shuck their foot, it'll cause pain, and it just doesn't feel right. And I think some of that, we don't expect most people to be able to differentiate between a stable and an unstable Lisfranc sprain. I think ultimately that is determined with x-rays and stress x-rays and potentially an MRI. So I would caution any athletic trainer to try to differentiate that basically based solely on exam. I think because some of these guys are tough. Some of these football players walk around on these things for a couple weeks before they come to see anybody, and I've seen completely unstable Lisfranc sprains that guys are just walking around and they can't play, but they're tough enough to make themselves move. So I think you really have to be suspicious of a sprain, and I think that in order to fully evaluate these patients, it's absolutely essential to have x-rays. So I wouldn't even recommend trying to differentiate the two types of sprains. I think all these people need to be sent on for x-rays, because missing one it's really a terrible problem for the patient or athlete. So
getting that referral out there.
Yeah.
So the next thing that you talked about was the Achilles rupture.
Yeah.
Obviously not in, and you said not extremely prevalent in the high school setting. More in the professional sport, more in the collegiate. I know I've seen several in the collegiate sport, on the collegiate side. More in the what you said, the weekend warrior, that 30+ male.
Yeah.
But kind of go a little bit into that. Kind of what are the things that, because for us as athletic trainers, either working at high schools, colleges, we're going to see a lot of active individuals. We're going to see, we may be active individuals that are in that age range. Right. And what can we help to prevent, and what can we kind of keep an eye out for?
So I think, the first thing I'd say is you guys all take care of teams, mostly probably high school, some college teams. But the bottom line is you guys are sometimes the first line medical providers for the families of the student athletes, or the coaches, or the some of the ancillary people around the facilities that sort of depend on you to help them with their musculoskeletal care. So I think even though high school athletes, I would say, rarely have these injuries, the people around you that are associated with athletics are potentially going to be more at risk, and you're going to see these in other coaches and the family members. So, one thing I would say to look for is a lot of these injuries will have a prodromal period of pain localized to that mid-substance of the Achilles. So whether it be a tendonitis or some early tendinosis, we know that a lot of these players have pain prior to their rupture. I always ask them if they do. I think that's important. And if they say, Doc, I had this large lump in my tendon and all of a sudden, popped the other day, that tells me that their tendon quality may not be the best. I can sort of guide them on, maybe this the outcome may be somewhat compromised by the poor tissue quality there. Not that it's going to change my approach in most athletes, but I think that's key. I think for those players or coaches who come to you and say, listen, I've got pain in my Achilles, and if they've got a big knot there where they're either swollen or in their peritoneum, or they develop some tendinosis or scar tissue in that tendon, I think those people need to be advised that you're at a higher risk of rupturing your Achilles, and you may want to dial back on the running, start your eccentric calf exercises, really get down to treating that prodromal tendinosis or tendonitis that could end up resulting in an Achilles rupture. So, I think those are the key things. There are some medications that are associated with Achilles ruptures. We know that the fluoxetine, ciprofloxacin, Levaquin, I've seen multiple patients who develop tendonitis or tendinosis after taking those meds, and I've seen multiple ruptures following even a short course of treatment with those antibiotics. So, that's another thing that I ask patients about. Some patients come in volunteering that information because they've read about it on the internet, and I think it's real, and we know it's real. So, just another consideration, when we're treating athletes with little infections that happen in the locker room, we try to stay away from those antibiotics, and if they do come in complaining of pain and they've been on those antibiotics, we try to recognize that and treat their symptoms.
Do you see any of it coming along with kind of those individuals that don't have a lot of dorsiflexion anyway? They may be a very tight individual. They may be they just don't have that good ankle mobility. There's a lot of seeing a lot of athletes move. There's a lot of those athletes that don't that have that limited ankle mobility. Do you see that more so?
Yeah. Absolutely. I'm a huge believer in sort of the gastroc is the root of all evil when it comes to foot and ankle problems, and I see a ton of Achilles tendonitis, tendinosis, plantar fasciitis, forefoot pain. All of these problems can be precipitated by a tight gastroc specifically, and sometimes a tight Achilles. I think it's important to isolate where the contracture is coming from. So when you're examining these athletes, you need to examine their dorsiflexion at the ankle with their knee extended, and then with their knee flexed to 90 degrees. The gastroc starts above the knee, and when you flex the knee, it relaxes that gastroc. And a lot of these people will have normal ankle dorsiflexion with the knee flexed to 90, whereas if I have their knee extended, they lack sometimes 5 degrees to get to neutral. So in those patients, I specifically advise them on stretching the gastroc, and in order to do that, a lot of these patients are doing calf stretching, but they're leaning against the wall, they've got their knee bent, and they think they're stretching, but they haven't. In order to isolate your gastroc, your knee's got to be extended when you're stretching. So I think that's an important thing to sort of catch on or to pick up when you're examining these athletes, and to diagnose and treat. Otherwise, that's probably the most common cause of plantar fasciitis, and often leads to both insertional and non-insertional Achilles problems. So I usually send these patients to therapy right away and get that sorted out, and a lot of times they get better just with some calf stretching.
One of the other things, kind of going off of that, where you were talking about your testing, I've seen a few Achilles ruptures, so I've not had the actual ability to play with your Thomas test and as much, but it was kind of interesting where you showed the video where they are truly getting some plantar flexion even with a complete rupture. So that's one thing that I guess we wouldn't think about as much as, all right, let's just test. And that kind of goes back to the old days of learning your special testing and making sure you're doing bilateral testing, because you can actually do a comparison.
It's very, very important. And, I know that from personal experience. I'm a victim of an Achilles rupture that was misdiagnosed by a doctor in the ER. And I walked around on that thing for 3 weeks and walked pretty well, because at the time I had a pretty good deep posterior compartment and was able to plantar flex pretty effectively. And when I went into the ER, they did the Thompson's test and said, you got plantar flexion, you don't have an Achilles rupture. And, come to find out, I was suspect of that diagnosis, and but nonetheless, you place a lot of trust in doctors and your medical personnel, and I think that you have to be vigilant and you have to do contralateral testing because these patients with a complete rupture of their Achilles, they're going to have decreased resting plantar flexion. Just put them prone on a table, have them bend both their knees up to 90 degrees. That way you can look at what their resting plantar flexion is at both, at the non-injured ankle and the injured ankle. That's going to be your giveaway. I mean, the Thompson's test is just sort of icing on the cake. If they don't have if their Thompson's test isn't symmetric, then 100% complete rupture. And I have patients ask me all the time, well, don't we need to get an MRI? And I tell them, no. I mean, there's clearly your Achilles is not attached to your calcaneus. You have no tension there. You can palpate a gap, and your Thompson's test produces very little plantar flexion, if not, sometimes no plantar flexion at all. So I think examining the normal side is absolutely essential in diagnosing these injuries and getting them treated. So,
especially you think about some of those large football players, larger athletes.
Yeah, they've got huge calves and they're deep posterior compartment, that FHL and FDL and posterior tib. They're going to be big. I mean, you can easily squeeze that compartment and produce some plantar flexion. So, in those patients, you really have to be comparing the other side and sort of taking the whole examination and coming up with a diagnosis. So
it's always good when you're on a live podcast and you start talking about the wrong test. That's always good.
I
It's
caught
close.
that, but I certainly wasn't going to point it out.
Yeah, hey, I'll point it out all day long.
Sorry. All right. You mentioned the calf stretch, so the leaning against the wall one. I'm a big fan of the foam roller. Do you feel like that using a foam roller stretches the gastroc?
I don't know.
You don't
I mean, I wish I had an answer for that.
Okay.
I think the foam roller's helpful. Athletes love it.
Well, actually, I hate doing it on my calves.
Yeah.
It's hurt, and I'm over 30, and I'm active. So
Yeah.
I'm thinking, all right, maybe I really need to do this because if the gastroc is the problem, then
I think it may be useful. I don't know what the literature, whether it supports it or not. I'm sure there's been some physical therapy literature or athletic training literature that potentially has looked at that. But, it's pretty easy for patients to do the wall stretching or stretching with a towel at home solo. So the rolling may be a little bit more difficult for some of my patients to do on their own and requires purchase of equipment. So, but I think that in the athletic training setting, and if you've got those resources in your training room, why not use them? They're definitely not going to hurt anything.
Especially since a lot of those individuals that you're talking about, the weekend warriors, are going to the gyms, and they've got those at the gyms. And, they've got those at CrossFits, and they've got those at weight rooms. And depending upon where you're going, if there are people those are a lot of the people that are going to those type of places.
Right.
Could be something that's there. So, well,
Good.
yeah, I'm good. Yeah.
all right, Dr. Greaser, if somebody wants to get a hold of you, what's going to be the best way to do that?
Well, I've got a website. You can go to www.michaelgreasermd.com, or you can find me on the UT Ortho website, and happy to answer any questions or evaluate anybody who needs to come see me.
michaelgreasermd.com. Check them out. Let them know if you have any questions, comments about the podcast here. Thank you for being here at the Sports Medicine Update, sharing your knowledge, and then taking time to interview with us.
Absolutely.
It was a great
It's
talk.
Thank you.
Appreciate it.